This could be a reason where you get a lot of contradictory conclusions in various studies, because in many of the studies it is not whether they have not studied whether coexistent adenomyosis was there or not. So if there is adenomyosis, it reduces the success of the surgery. Then comes the peritoneal disease. Peritoneal disease is one way it is good, one way it is a bad. Peritoneal disease is normally in the form of implants and peritoneal adhesions. This peritoneal adhesion can be peritubal, periovarian, in the deep pouch of Douglas. This because of this peritoneal disease, the oocyte quality is hampered because lot of inflammatory cytokines are there. So if you have dealt with peritoneal disease, then your chances of success is much more higher. Even if you have left behind a small endometrioma, even if you have left behind a deep pelvic endometriotic nodule, but if you have taken care of peritoneal disease beautifully, it helps in enhancing the success rate of the surgery. Then comes the endometrioma. The endometrioma already, because it's a progressive disease, with the endometrioma there is already low AMH level, and if you operate the endometrioma with the already low AMH level, your chances of getting her pregnant reduces. So it is not a good idea to operate on the endometrioma unless it is absolutely indicated, especially with the diminished ovarian resolve. So basically, how to operate on the endometrioma? Three, it downgrades the lesion. So those moderate endometriosis becomes appears like mild endometriosis. So it is amenable to simpler treatment like IUI. Four, in case of IUI, IVF, it facilitates the ovum pickup and it enhances the success. So this was in nutshell how surgery helps in infertility. Now, what is the place of IUI in endometriosis? In case of milder endometriosis, normally we treat it as a unexplained infertility, and we all know unexplained infertility. The most effective treatment after IVF is IUI only. The surgical corrected pelvic lesions and restoration of TO relationship with healthy tubes. So if the tubes are healthy, surgically you have corrected the pelvic peritoneal nodes and adhesions, and you have restored TO relationship. These are the good cases to subject for IUI treatment for limited period. Now, which is the best drug for IUI? Gonadotropin with IUI gives the best result. In little inferior to that is CC with IUI. Inferior to that is only IUI. This is in comparison with the expected treatment. But you must understand, overall endometriosis has decreased per cycle conception rate compared to a male factor and unexplained infertility, and result plateau after 3 to 4 cycle. So timely decision for IVF should be considered when in the case of endometriosis. What is the role of aromatase inhibitor? Because we all know there is a higher expression of estrogenic status, and it causes higher inflammatory, it increases the inflammation in the endometriotic implant. So theoretically, yes, aromatase should be effective in endometriosis, but study doesn't conclude uniformly. The Abu Hasim et al. They say that there is no difference between AI and CC in stage, at least stage 1 and 2, whereas the Miller et al. In 2012 concluded that the aromatase inhibitor might improve IVF success by improving the endometrial receptivity. Now, the very recent study, the aromatase inhibitor are advocated along with the leupride depot, that is agonist depot down regulate down I mean depot for when you are down regulating before embryo transfer. They advocate to use aromatase inhibitor along with that. So, if even in case of recurrent implantation failure, when you really do not know what is happening, because there are several cases of endometriosis, mild endometriosis, which could be responsible for altered endometrial receptivity. So, by using aromatase inhibitor along with the agonist depot, it takes care of such negative aspect of minimal or mild endometriosis which were not diagnosed before, especially when you're dealing with the recurrent implantation failure. So, what are the indication for IVF in case of endometriosis? So, when there is a quantitative decline in the ovarian reserve, that is diminished ovarian reserve. When the female age is 37, more than 37, I would put in Indian scenario more than 33 or 34, because here the diminished ovarian reserve, chances of diminished ovarian reserve starts quite earlier as compared to the European partner. So I would put 33, 34 years, because there is a qualitative as well as the quantitative decline in the ovarian reserve. When the infertility duration is more than 5 years, enough, you're given enough time for spontaneous conception, and if she is not conceived with this milder treatment or the spontaneously, then it's a time to go for IVF, because ultimately endometriosis is a progressive disease and there is a progressive follicular depletion. So it's a high time to go for IVF. Failed control ovarian stimulation with IUI cycle, 4 cycles you tried in milder endometriosis, or maybe surgically corrected endometriosis, or maybe post-operative endometrioma, post-operation endometrioma you tried and it's not working, it's a high time to go for IVF. When there is recurrent endometrioma, big no to surgery. When there is a bilateral endometrioma, surgery is to be avoided. When there is a coexistent adenomyosis, better to go for IVF, because in IVF before transfer you have chance to downregulate the pituitary, and following that the adenomyosis becomes calm, and the negativity of the adenomyosis on endometrial implantation is reduced to a larger extent. When there is a bilateral tubal factor, means coexistent male factor or bilateral tubal factor is there, then it's a time to go for IVF. So these are the indication of IVF in cases of endometriosis. Now this has been discussed while surgery, but very important point only I will touch upon. Uh, Surgery first. If we do a surgery first, what are the problem? And if we do IVF first, then what are the problem? If you do surgery first before IVF, then the most the touching point is there is an impact to the ovarian reserve, and there is a risk of premature ovarian failure. That's the most important point to understand. And if you do IVF before operating on the on this severe endometriosis, there is increase in the inflammatory region, but the true problem which we are likely to face is endometrioma infection, if at all it is there. And probably we are dealing with undiagnosed occult malignancy. There is a risk of rupture with the subsequent chemical peritonitis, and patient becomes pregnant, and you have not treated severe endometriosis. There are certain complications which starts occurring once he becomes pregnant, which we are going to enumerate little later. And most important, there is a difficulty in oocyte retrieval, because you do not know if the location of the endometrioma is such that your access to those developed follicle is not possible without puncturing the endometrioma. It's a great difficulty. So you need to operate such case before jumping to the IVF. there is a large evidence, there is a good evidence that in patients with endometriosis associated infertility, the surgery followed by IVF is more